Good morning, everyone. Welcome to TeleShadowing. We're now live on Zoom and YouTube. Feel free to ask questions as we go along and they'll be addressed. So today we are going to be having a special session for our Neurology Month, specifically focusing on psychiatry. If you go on to the next slide, we'll be also going over a couple of different case studies and also a brief history into psychiatry as a field. We'll also be doing a little bit of MCAT prep relevant to the psych-soc section on the MCAT. So without further ado, Dr. Shima, feel free to take over and discuss us through our case study.
Very good morning, everyone. It's Saturday morning. We are here again today to learn together. So today we're going to talk about clinical depression. Since it's a neuro month, we are learning about psych. We learned about neurotransmitters last week. We talk about the happy hormones. So let's talk about what is clinical depression. So basically, it's a mental health disorder characterized by persistent depressed mood, or there are many symptoms, like there's a loss of interest in activities, causing the significant impairment in daily life activities. So like possible causes include a combination of both biological, psychological, and there are social sources of distress that can cause the depression. And excuse me, research shows us that there are many factors and cause changes in the brain function that we'll talk briefly about it that can cause a depression. It includes the altered activity of certain circuits in the brain. So we'll see how it looks on the imaging, how the neurotransmitter changes, and how we can manage. And then we'll talk about the case study. So basically, clinical depression is considered one of the most treatable mood disorders, but neither the condition and nor the drugs used against it are fully understood. But there are many hypotheses that support this terminology. So first of all, it's a persistent feeling of sadness or loss of interest that characterizes major depression that can lead to a range of behavioral and physical symptoms that may include like a change in sleep, change in appetite, we feel change in our energy level, our concentration level, our daily behavior, or most importantly, our self-esteem. So basically, and sometimes depression can also be associated with the thoughts of suicide. So these are all different, we can see symptoms and signs in the depression. So there are neurobiological causes that contribute to the major depression. So basically, it's a complex relationship between the serotonin dysfunction and there's a hypersensitivity to stress, and there's a vulnerability to developing major depressive disorder has been considered that serotonin is the main neurotransmitter you can talk about. But in addition, there's a dopamine is also increasingly thought to play a vital role in the pathophysiology of the major depressive disorder. So basically, it's a chemical imbalance in the brain during depression. So as last week, we talked about the happy hormones, and we talked about serotonin, dopamine, how they're areas from where they're released from the brain. And then these chemical imbalances in the brain causing the depression. So basically this, excuse me, I have a little bit sore throat, so excuse my voice as well. So the chemical imbalance theory suggests that depression results changing levels of neurotransmitters located in the brain. And the most common evidence used to support this chemical imbalance theory is the effectiveness of the antidepressant medication. We'll talk briefly about it as well. So let's talk about the serotonin versus dopamine. So dopamine imbalance can cause depression symptoms such as apathy, feelings of hopelessness, and while the serotonin imbalance can can affect our processing of emotions. And last week, I will go over again the anatomy in the brain, which structures involved hippocampus, hippocampus, and the amygdala, main organs, the main parts of the brain. So basically, where in the brain is depression located? So the main subcortical limbic brain regions implicated, you see in this diagram as well, implicated in the depression are the amygdala, the hippocampus, and the dorsomedial thalamus. So both structural and functional abnormalities in these areas have been found in the depression, and patient has depressive disorder. So I would like to talk briefly how the depressed brain versus a normal brain. So we can see on the imaging as well, when comparing a depressed brain versus a normal brain. So research shows us, and scientists have found that some subtle but very important differences, including the gray matter abnormalities. And what happens? There's a brain shrinkage, and more active amygdala in depressed brain. So you can see in this imaging area. So there's a more highlight, normal brain is the more highlighted area, and there's a less hyper, you can say there's not much stimulation in the depressed brain. So what is happening, excuse me, in the brain during depression? So MRI study shows that there's a decreased brain activity in the hippocampus. As I showed you in the previous diagram, I showed the way hippocampus is. It was reported on the MRI that there's a decreased brain activity in the depressed patients. And what else? There's a reduced gray matter volume, and there's a reduced functional activity in the hippocampus as well that lead to the negative emotions and the inability of cognitive processing in depressed patients. And also we can see, excuse me, on the PET scan. So when the study was done on the PET scan, it shows that when we compare the brain activity during the periods of depression, on the left you can see with the normal brain activity, and on the right, there's an increased blue and green colors you can see. So that is along with the decreased white and yellow areas. That shows the decreased brain activity due to depression. So this is how we can see brain scan matters like MRI, CT scan can help measure the gray matter volume thickness, gray matter volume, their thickness, and the shape. That tells us, and abnormalities have been documented on the imaging that shows us most appears on the imaging when patient is depressed, like depressive disorder, anxiety, and ADHD patients. So let's talk about on the MRI studies that support reduced brain volume in the patients with depression as compared to the group of healthy individuals. And again, you can see the brain decreased activity in the hippocampus, putamen, and caudate nucleus. So I will show you in the next imaging. Can you please go on the next so we can see the anatomy, where is the putamen, hippocampus? Here we go. All right. So this diagram, I put it for you guys so you can have an idea where is the hippocampus, putamen, and caudate nucleus. So let's go over talk briefly. What are the causes of depression in adults? So it's thought that it's not only just one factor. Anyone who is very severely depressed, there are many factors, and most importantly, can be affected by the genetic makeup. The genetic you have inherited from your parents. There are multiple stressful events and causes, our personality, our family history, sometimes stressful events like pregnancy, childbirth, menopause, loneliness. That's why we say we should have a good social bank. Many drugs can cause it. So illnesses, many medical conditions can cause it. So as we talk about the serotonin and dopamine, so I will talk briefly about what causes the serotonin deficiency. So basically, this low serotonin can happen because our body does not make enough. That can cause it, and it does not have enough certain levels in our brain can cause depression. And there are several factors that can cause to it and contribute to it, like genetics, stress, chronic pain can cause it, and most importantly, a nutritional deficiency can cause it. So as you know, I always talk about the self-care, and I stress all the time, healthy diet. So there are three key foods that deplete the serotonin. And the neuroscientists had a study done that shows that very much sugary snacks can cause depletion. Food high levels of trans fat can cause low serotonin levels, and the highly processed foods. So always try to eat healthy food. And there is no single cause of depression. It can occur for variety of reasons. So you keep in mind, it's not just one single factor can cause it. So as I was talking about the serotonin, so how we can increase our serotonin levels naturally. So as we talked about last week as well, so I'm going to go over again for your health as well, for your well-being, for your self-care, exercise, physical activity, exposure to the sunlight can cause natural increase serotonin level, adequate sleeping hours, meditation, mindfulness practicing, social connection, try to increase your social bank, healthy, positive social bank, support system around you, manage your stress level. These are all different ways we can improve our serotonin level as well. So how can we rewire the depressed brain? Can we do that? Yes, we can. So depression is basically, as we talk about multiple factors, is correlated, as I showed you on the imaging as well, is the atrophy of the neurons in the cortical system and the limbic brain regions that control our mood and our emotions. So how we can rewire? Sometimes we use the antidepressants. We use it. I will talk very briefly about it, SSRIs, and that can exhibit the neuroplasticity and reverse the neuroanatomical changes found in a depressed patient. So, as I mentioned, we can rewire brain. We can repair our brain. Sometimes brain repair itself after depression. So there are many studies that shows that depression changes may be reversible and brain can heal. So to treat, there are many medical treatments. There's a cognitive behavioral therapy can help. That can help reduce the inflammation caused by the depression, and also the brain there can form the new synaptic connections that were compromised during depression can help. So as I talk about the antidepressant and the antidepressant SSRIs, the selective serotonin reuptake inhibitors, they can help us to rewire our brain connections. So there are many clinical trials that reveals the first evidence of how the brain restructures physically in the first month use of the SSRIs and the link between the neuroplasticity and the depression. So SSRIs, and there are many fluoxetine, serotonin, so paroxetine, there are many SSRIs that can help to rewire our brain. So mainstay treatment of is usually a medication. There is a combination with the cognitive behavioral therapy, psychotherapy, and there's a multiple research shows that there are many treatment that can help our brain changes to be normalized with depression. So that's all about the clinical depression. I will pretty quick go over the case study. So let's go over the case study, and I would like one of our medical students to go over, and then we'll talk about more about this case study.
Sure, I'll read the case study. 3 months after witnessing her best friend being shot to death by another classmate in school, a 14-year-old girl is brought to the office by her parents because her teacher says that she seems to be having trouble concentrating. Ever since that awful day, she has been very sad and withdrawn, often sitting on her bed and staring at the wall for hours. She has frequent crying spells and refuses to play with her friends or participate in her normal after-school activities. Her appetite has dwindled down to nothing, and she feels very guilty that she survived the shooting. On further questioning, she reluctantly admits that she has constant thoughts of joining her friend. She did not receive any counseling after the incident. So, question on this is the first question for this case study is asking the most likely diagnosis is A,
Okay.
adjustment disorder, B, brief psychotic disorder, C, dysthymic disorder, D, major depressive disorder, or E, normal grief.
Good, very good. Thank you for reading, Minahil. So let's go over all these options. So what you guys think? What's going on? So as Minahil read all the scenario, what's going on with the patient. So the most likely diagnosis is the patient has a major depressive disorder. So now let's talk about why. So in this scenario, the patient meet the criteria for this disorder as patient exhibits the 2-week history of a distant change in mood. Patient has a loss of interest, patient along with at least 4 of the following. First of all, appetite. It can be decreased appetite with the weight loss, and patients sometimes have eat too much. They can gain weight. Then difficulty sleeping, psychomotor retardation or agitation. Patient feel more tired, fatigued. Patient has a feeling of worthlessness or guilt or hopelessness, and patient has inability to concentrate and sometimes patient has a suicidal ideation as well. So that's the reason these all the symptoms must cause the functional impairment. So these are all the symptoms in our patient. That's why patient has the most likely depressive disorder. So let's go over the other options. So choice A is the adjustment disorder. So this patient's suicidal ideation marked functional impairment make this option incorrect, given it's not an adjustment disorder, because in adjustment disorder, which may develop in response to a stressor, that is characterized by the depressed mood and other symptoms that are similar to those symptoms but less severe than the symptoms of major depressive disorder. So in this scenario, patient has a more severe symptoms. That's the reason we will rule out it's not adjustment disorder. And also, if a patient meets the criteria of major depressive disorder, we cannot diagnose her with an adjustment disorder. Also, individuals with the adjustment disorder typically return to baseline functioning within 3 months. And then let's talk about the choice B, the brief psychotic disorder. So brief psychotic disorder characterized by the delusions, hallucinations, patient has a disorganized speech and grossly disorganized behavior lasting for more than a day but less than a month. So that's why we exclude it's not a brief psychotic disorder. So patient does not fit in that criteria. And then let's talk about choice C. Why not dysthymic disorder? So dysthymic disorder characterized by the depressed mood for more than 2 years. So this is how you will differentiate. And this patient has been symptom for only 3 months. That's why you will rule that out. And let's talk about a normal grief, the option E. So normal grief is basically an expected reaction to a loss of a loved one. So basically, it is characterized by the feelings of loss, feeling of sadness, and loss of enjoyment, or you can say decreased enjoyment. And individuals with the normal grief, it's a normal grief, may experience frequent crying spells and possibly have some minor dysfunction, but it lasts for only few weeks and months, but may last longer. But in major depressive disorder, is diagnosed there is a suicidal ideation and feelings of worthlessness and guilt. That's why it's not a normal grief. So let's, Minahal, can you read this next?
Yes, the next question is asking the most vital question to ask at this time is A, are you hearing voices? B, do you have any friends that you feel comfortable talking to at school? C, do you wear a helmet when you ride your bicycle? D, can you describe your typical weekly alcohol intake? Or E, have you thought of the means by which you can join your friend?
Good, thank you. So what do you think? What is the next question we should ask this patient based on her scenario, based on her presentation? So the correct answer is E. Why? Because patient has already told you that he has suicidal ideation, right? And joining her friend. And it is very important to ask if she has thought by of the means by which she can join her friends, or if she has made any preparatory actions. So this is the most important question you need to ask the patient. So let's go over one by one, why not the other options? So choice A, options A. It may be important to ask the patient if she is hearing some voices uh, to determine if her depression is associated with psychotic features. So as we talk about the hallucination, delusions, these are all the psychotic features. However, this will not change the immediate management. So as we already found that patient has constantly thinking about joining her friend. So now we need to question her about a plan. Should be that's what E is the next best option to ask her. Let's go over the B option. So though patient is, it is very important to find out if she has friends that she can confide in, asking her, do you have any friends you feel comfortable talking to at school? But it's not vital at this time. We all need a social support. So that's important, but not the next step. So let's go over the option C. So it is also very important to counsel the patients to have a protective measures, like wear helmets while riding bicycle. However, this is not the most vital question to ask patient with a suicidal ideation. So we have to be very vigilant with the patient with a suicidal ideation. And let's go over the option D. So all adolescents should be asked to describe their use of alcohol use, any other drug use. However, this is not the most vital question to ask to this patient with the suicidal ideation. So let's go over what is a PHQ-9. So basically, PHQ-9 is a screening tool we use as a diagnostic assessment in the primary care setting. Basically, it's a 9-item patient health questionnaire. You can see in this diagram. So we give this questionnaire to the patient and ask about these different questions to rule out. Basically, it's PHQ is a patient health questionnaire to depressive symptom scale and diagnostic tool. It was introduced in 2001 to screen adults in primary care settings. And the instrument assesses for the presence and severity of the depressive symptoms for possible depressive disorder. So this, I will go over how we say no depression or mild depression or moderate or severe depression. So this is the questionnaire we ask. All these questions we do ask them about, as we ask about these things, interest in doing things, feeling down, depressed or hopeless, excuse me, trouble feeling, staying asleep, any sleeping trouble, feeling tired, any lack of energy level, appetite we can ask about. These are all the scoring system. 1, 2, 3, we label them. And then feeling about self, how they feel. And next, please. So then we ask about focus, concentration, and then as checking about speaking, moving, speaking slowly, and then thoughts, suicidal thoughts. So these are all the questions we ask. And when we check, so we then number them. Next, please. So this is how we assess them on this PHQ, based on this PHQ-9 patient depression questionnaire. Next, please. And this is a total score. I will show this table. So a patient score between 1 to 4 is a minimal depression. Then 5 to 9, if patient score between 5 to 9 is a mild depression. 10 to 14, moderate depression. If patient score 15 to 19, moderately severe depression. And 20 to 27, severe depression. So this is how we diagnose, a diagnostic tool. So after we have a diagnostic tool, we assess the patient. So then we have a better idea where patient is. So then based on that, we treat the patient. I will not go in detail. I just talk briefly about the SSRIs, how interlink between the neurobiology, between the neurotransmitter, and I talk about the natural ways we can improve our serotonin levels to keep ourselves healthy and in a good mood. And I will stop here and I will ask our medical student to go over about a few criteria, how an MCAT, it will help you to answer your questions. And most importantly, at the end, I will go over briefly how you have to care your self-care. And I will tell briefly self-care, why you need to be, briefly talk about why you need a self-care. So I'll stop here and I will request our medical student to go over the MCAT portion. Thank you.
Thank you very much, Dr. Chima. I know I learned a lot. It's very relevant, these types of questions related to the USMLE Step 1 as a medical student. And but now we're going to kind of switch gears and talk a little bit more about why is this overall important? Why is the impact of psychiatric illness relevant, even if we don't pursue psychiatry? So if you go on to the next slide. So I wanted to ask everyone here, what is the leading cause of disability in the United States for the age group of 15 to 44? It's actually major depressive disorder. And essentially, according to the WHO report, it's actually, if you're thinking more about the leading causes of years lived with disability, it includes back and neck pain, diabetes mellitus, some depressive disorders, anxiety disorders, and also drug use disorders. So depressive, anxiety, and drug use disorders, all three of them fall under the psychiatric category. All right, so I wanted to go over some of the stats and figures to really understand the scope of psychiatric illness. So 700,000 people die by suicide annually globally. In fact, also 1 in 7 adolescents are diagnosed with a mental health disorder, and also Um, in fact, people with severe mental illness, they actually die 10 to 20 years earlier than the general population. So even if you're not a psychiatrist, if you are a primary care physician or an internist or even a surgeon doing a pre-op, you will likely see and encounter a patient with a psychiatric illness, and you'll be able to see the medication that they take. So it's very important and relevant to all of us, regardless of the specialty that we choose to go into. All right, now we're going to go over like basically this brief history of psychiatric illness. Unfortunately, there have been many ethical principles that were compromised in the past, and it wasn't very great for a long time. Unfortunately, there were so many horrific things that happened in the past with for patients with psychiatric illness, mainly because it was very less and not really commonly understood. And so that really associated a lot of stigma as well. So they say that psychiatric illness is as old as the human condition, because all the way back, if you've taken AP World History or any world history class, we always start off with ancient Mesopotamia, which is one of the first civilizations in the world that date back all the way to 6500 BC. It basically has mentions of individuals hallucinating and giving them spiritual meanings to predict future events. In fact, this is also around the time when people started doing funeral processions and actually burying their dead. Um, and also, basically, these ancient Greek texts have also referred to these specific manuals that care for the insane. And then let's move on to medieval times into the 17th and 18th centuries. Basically, mild mental illness used to be treated with spas and spa doctors. In fact, fun fact, the Romans, they used to actually drill 3 holes in skulls back in the day for just to treat headaches and sometimes psychiatric illness as well. And then in the cities that were more densely populated and had more resources relative to rural areas, patients started being held in institutions or the early asylums. Most predominantly, or I guess the most well-known and oldest one of these is a hospital called Bedlam Hospital. It was founded in 1247. So about, over, if we do the math correctly, 2024 minus 1247, over 700 years ago, that was there. And in rural areas, the care of mental illness, because there weren't any institutions available, it was primarily left to families to really take care of the patients. And unfortunately, it subjected patients with mental illness to sequestration, which basically means that these patients would just be locked up in their homes or locked in a specific room and just really isolated from the rest of society, basically, because there were no other resources to really take care of these people. And so just to talk a little bit more about the Bethlehem, or Bedlam nowadays is known as Royal Hospital. It's founded in 1247. It had a lot of horrific things that occurred. You can see in this picture. Let me actually turn on my, if I can annotate and arrow. Yeah. All right. So you can see here, this is a patient who's actually shackled, a nurse really taking care of it, there and just sort of keeping him down. In fact, this is actually, you can see there's a spot on his chest. There's actually the bloodletting that would occur to these patients, where they would basically like bleed out patients to try and see if that would help their psychiatric illnesses. These are actually jail cells. It's a little harder to see in the back of the picture here. These are basically prison cells that they would put patients in. So it was actually England's first asylum for treatment of mental illness. Now, I don't know if there's a lot of treatment going on, or maybe, it might have had good intentions to begin with, but unfortunately, because people did not know um, the biological basis of a lot of these mental health illnesses, they did not know the best way to treat them. So that led to a lot of horrific tragedies that occurred. So now we'll continue on to the Enlightenment. Now, things did not necessarily get better, but at least in the 1700s, there was this concept introduced of the curability of mental illness, that it can actually be cured, exploring multiple types of therapeutic options. Now, we don't know if all of them are ethical today, but there are still some that are used today that were based on specific illnesses. And then in the 1800s, that was when the rise of the asylum occurred. Basically, this was also well intended, but unfortunately poorly ended, because asylums ended up turning into sort of prison cells. And if this was initially infused with something called moral therapy and strict daily routines, which just did not end up being successful. And there were numbers that were very overwhelming the system. In fact, there's still a psychiatric bed crisis today, but in 1820, there were 57 patients basically in a system, and then 57, I think, thousand, and then in 1870 it increased to 473,000. So just in 50 years, there were many thousand patients who are considered chronic patients, patients with alcoholism, neurosyphilis, senility. So there was a huge overwhelming of the system. Oh, my bad, the arrow there. But basically, unfortunately, this did not work out very well. But then now that we're getting closer to modern day, let me turn off my pointer. All right. Basically, in modern day, the word psychiatry was finally coined after World War II in 1808. Before this, actually, psychiatrists were known as alienists, which is also something to consider when you're thinking about why has there been so much mental health stigma for so long. It is getting better today and now and in our generation, but in previous generations, there was a huge stigma towards mental health overall. So now the previous alienists are now known as psychiatrists. In fact, in the late 1800s and 1900s, that's when the fall of asylums occurred. Therapy started becoming more common practice, and also the rise of day hospitals or the modern day hospitals that we see today. And now as we move on to the late 1900s, we're thinking about we're seeing now the rise of psychotropic drugs. Now there were some questionable drug and treatment choices made before the 1950s, such as morphine injections, hyoscyamine. There was also something called the chloral hydrate knockout drops, a bromine sleep cure, which not done today. Insulin coma is done in the past, which clearly violates our Hippocratic oath of do no harm, because some of these quote unquote treatments were actually doing more harm than good to our patients. There were also sometimes seizure inductions performed, which that's not done anymore, but there is still electrotherapy done sometimes for specific cases, and also lobotomies, which are not commonly practiced today. That's sort of old medicine. And then in the 1950s, chlorpromazine chlorpromazine was actually introduced as the first antipsychotic that was developed. Then it was followed by lithium, imipramine, and then Prozac, which is like modern day standard typical antipsychotics. Now moving on to DSM-5, you might have already heard about it. But what specifically is that? Basically, the DSM-5, DSM stands for the Diagnostic and Statistical Manual of Mental Health Disorders, where the first edition of it was released in 1948. So you can see here the 1950s and onwards is when psychiatry as a field was developing and becoming more ethical and becoming actually safer for patients, although it's a long ways away. But it became much more useful to organize and categorize these mental health disorders for children and adults. It also reflects this consensus of basically the current knowledge that's classified by the American Psychiatric Association, and it provides basically the most standardized research and diagnoses, like basically the textbook definitions of things. But it's not used in every single country. It's used in a lot of countries, but not every single country uses a DSM-5. But of course, it's developed in America, so we do use the DSM-5. But of course, real world and textbook definitions can sometimes vary. So we don't use it as an end all be all. In fact, like a lot of DSM-5 presentations, they can actually result from another medical condition, or they could be like medication or substance induced. Basically, it could be a side effect from a specific medication, like hypothyroidism and depression. There could also be something called steroid-induced psychosis. So it's important to rule out medical conditions and medication and substance-related reactions or side effects first, or concurrently when you are making a psychiatric diagnosis. So this actually brings me to something called the psychiatry. This is something I learned at my medical school. Basically, it's a little blurry, but essentially it goes over like you can see there are branches, specific branches here. So if I'll take my arrow. So there's something called there's mood disorders, anxiety disorders. Here it says psychotic illnesses, cognitive disorders, childhood disorders. So for purposes of time, we're not going to be able to go over every single branch and root, but I would say that this is a very good overall picture of the field of psychiatry. So on the next slide, we'll just briefly go over like childhood disorders that we might have already heard of and might be relevant to the MCAT as well, such as neurodevelopmental disorders, including ADHD, intellectual disabilities, autism spectrum disorders, and also like disruptive, impulsive control and conduct disorders, which includes this disorder called oppositional defiant disorder and conduct disorder. And as for, I guess you could say the treatments of these childhood disorders, I'll go over them briefly. We need to know those, we need to know these for medical school, but for undergrad and pre-meds, we don't need to know them. But basically, to treat these types of illnesses, they take stimulants or norepinephrine releasers. A couple of these you might have heard of amphetamine, and D-amphetamine, dexmethylphenidate, and also methylphenidate. And also something called SNRIs, which includes like viloxazine. But that's sort of out of scope. But we also need to know, these illnesses, how to diagnose them at the right time, at the right place. That's personalized medicine, as long as well as the right treatment for the right patient. All right, this takes us to mood disorders that we already talked about today. Basically, there's major depressive disorder. It could be either single episode or recurrent, persistent depressive disorder, bipolar disorder type 1 and type 2. That is very high yield for the MCAT, cyclothymia as well, substance and medication-induced depressive disorder, and also just depressive disorder that may be due to another medical condition. So I just spent over two branches over all the branches of the psychiatry, but I hope that this was sort of helpful to kind of give you a good lens into what you're learning in undergrad or for the MCAT is still relevant when you're getting into medical school as well, especially since psychiatric illness, major depressive disorder, anxiety disorder, specific phobias, they are all very, very common in the general population. All right, this takes us to our MCAT prep section. We're going to be going over basically one passage from a full-length exam, specifically full-length exam 4 from the AAMC. So all credit goes to them for that exam question. So on the next slide, I'm just going to briefly go over that this is, sorry, my laptop is freezing. But essentially, let me see what I can do if I can close that out. All right, yeah. If you go back a slide, I wanted to actually briefly touch base on what exactly is this section on MCAT. It's basically section number 4, called the Psychological, Social, and Biological Foundations of Behavior section. Basically, the MCAT has 4 sections, and this is the last one. It has a total of 59 questions, which are like a combination of discrete questions, which basically means like standalone questions, and also passage-based questions. And you have a total of 95 minutes to answer all 59 questions. The disciplines that are tested include introductory psychology, like from your Psych 101 class, sociology from your Sociology 101 class, and also introductory biology, because as Dr. Chima mentioned, there are specific areas in the brain that are more affected. I'm remembering specifically from my MCAT, like Wernicke's aphasia was tested. So you need to know the Wernicke's area, right, of the brain. Because look, biology is relevant to our psychology as well. So there are a lot of other concepts, but you can also see it on the website. So I'm going to link it in the chat box now. Basically, the website that essentially goes over all the specific concepts that are tested on the MCAT related to the section. And usually, commonly, it's called the P/S or PS section. Now we'll get into our MCAT passage. So I'll read it, and essentially there are areas highlighted that I would normally highlight if I was taking this exam. So let me go along, and I will turn on my annotate button again, and let me see if there's like a color. Let me test this out. Okay, no, I'm looking for my highlighter. Draw. All right, no worries. If we can't find that, then that's fine. I'll just underline. All right. So this is one of my favorite passages on the MCAT, and I still remember it's very relevant to today's discussion as well. But I'll read it, and I'll explain my thought process as I'm reading it. Hopefully that might also be helpful than just straight up reading it. So low and middle income countries, defined as LMICs. So LMICs is an acronym. MCAT loves its acronyms, so I tend to highlight the acronyms so that I can keep track of the definitions. And so I don't have to keep because once they define an acronym, they're going to keep using that acronym. And if you are reading very fast and you're losing track of your acronyms, then you don't really know what's being tested. So, okay, so now I know LMICs are low and middle income countries. So basically, I'm thinking immediately, I'm just making like a cognitive dissonance, or just I'm taking some cognitive shortcuts right now, thinking of third world countries. They face a substantial disease burden from untreated mental, neurological, and substance use disorders. Research conducted with populations in LMICs is generally less extensive than research with populations of high-income countries. So now another acronym was introduced, HICs, high-income countries. So high-income countries, I would think of where I live right now in the United States or Canada or first world countries, essentially. So now at this point of this passage, I'm thinking, okay, I'm comparing third world countries to first world countries. I'm also thinking is making these cognitive shortcuts. After you do a lot of questions, you realize, you're on the clock, so you can't really talk to yourself during these. But this is sort of my internal talk that I'm doing with myself. So basically, the second sentence is just saying that the research that's conducted with the populations of LMICs, it's generally less, obviously, because it's less funded, and most scientific research is done in first world countries. That's where all the funding is, really. And so the third sentence says, until culturally tailored interventions can be designed and evaluated, efforts to improve mental health and LMICs are mostly based on recommendations from studies conducted in HICs. So think about it. If I'm thinking about now, here I'll make an example to sort of understand this sort of high level talk. So here I'm comparing, okay, America to Pakistan. So Pakistan is just my ethnicity, so that's the first dissonance I make. Like, okay, if I'm thinking about cultural differences, they're very, very different, because some practices in Pakistan, they're done that are not really heard of in America, but could also be helpful for treating a lot of things. So without this cultural awareness, and instead of providing a one size fits all solution that high income countries provide, I'm sort of just comparing, like, okay, the cultures are very different. And so if the recommendations are made by a culture that's kind of more privileged, it might not work in all areas of the world. So then the last sentence says, and the last sentence really sets the tone for the rest of the this passage here, and this is true for a lot of passages. The areas of study have included. So basically, now they want to specify which areas of study have recommendations that aren't really relevant for lower middle income countries. So areas of study have included depression. One, depression. So actually, let me start annotating. So depression, dementia, and alcohol AUDs, alcohol use disorders. So I'm like, okay, one, two, and then three. So now you can see here, I'm not even reading the rest of the passage, but you can see here, depression is mentioned, dementia is mentioned, and then also alcohol use. So I'm like, okay, one, two, three. So they separated these topics by paragraphs. Now this is just this is also like, this could be a coincidence, but I'm just like, okay, this is how I'm organizing my brain. Like, I'm going to be dividing these three areas of study that are basically comparing and contrasting high income countries, HICs, to LMICs. And they're basically like trying to defend what the claims that they made, like that until culturally tailored interventions can be designed. So depression is one of the leading causes of disease burden. And at this point, if I understand what's going on in the first, let me actually clear all drawings. If I'm actually understanding what's going on in the first paragraph, I sort of just read the first and last sentences of the rest of the paragraphs. It depends on how much time I have. But at this point, I will start reading the questions. Now that I sort of understand the stage, I'll read the questions and then come back to reading the rest of the passage if needed. So you can see number 47 is asking, underuse of available healthcare services for the disorders in the passage is most likely due to. Now, this is a question that's essentially testing your knowledge of definitions. So here, this could also be a discrete question in and of itself, because it's really just asking, do you know the definitions to these words, and which one can apply the best? So the correct answer to this one, you would think, is like, I think I got this one wrong when I was doing this when I first did it. Like, I said globalization. It's not globalization. I'm making an assumption. So it's better to read the rest of the passage. I will let you read it for a couple of seconds. I'll read it in my head, and then we'll continue off with the rest of the passage. So depression is one of the leading causes of disease burden in many regions of the world. And then the last sentence of that is the use of antidepressant medications. The prevalence of dementia is higher in HICs and in LMICs, which could be because of underreporting. And then the last paragraph touches on excessive alcohol use, which is associated with chronic diseases of the liver, heart, and brain. So I'll let you all pause if you want to read the rest of the passage in detail. And once you're back and once you've read it all, now I'm going to be basically going over the questions and answers. So this number 47, this is basically this passage related question, and also it could be a discrete, but it focuses on the three disorders that were discussed in this passage. In paragraph one, it introduces the depression, and dementia and alcohol use disorders, and then in the rest of the paragraphs they describe them in more detail. So basically, underuse of available healthcare services for depression, dementia, and alcohol use disorders is most likely due to one of the four vocab terms that I mentioned. So now in my head, I'll be going over each term, and if even if I don't remember like one or two words, I can also use process of elimination. So anomy. Anomy is basically describing the alienization or alienation that someone feels from a lack of social norms or this breakdown of social bonds. This is a sociology concept between their individual and community ties. So that leads to fragmentation of their social identity. Now, just from the get-go, is there any mention of someone being separated from this? Like it is possible that it could explain like the underuse of available healthcare services, but there's no like emphasis on the lack of social norms in this passage. So that's how I would just be able to cross off anomia. Then there's globalization. Globalization refers to the process, or according to like I guess AAMC, globalization refers to the process of integrating governments, their cultures, their financial markets through this international trade and a single world market. It's essentially like capitalism. So this would actually provide the opposite effect of globalization because the question is again asking like the underuse of available healthcare services. So the underuse is of healthcare services in lower in like LMICs. It wouldn't necessarily have to do with globalization, um, because it's a matter of integrating governments and cultures. Here we're trying to emphasize like we should be more culturally competent. So that's how we can cross off B. And then for C, cultural lag, this is basically referring to the notion that culture takes time to catch up with technological innovation, and the social problems and conflicts that are caused by this lag. And that's similar to A because there is no talk of cultural lag in the passage, and it doesn't apply to depression, dementia, or alcohol use disorders. And so we can actually just cross that off for now. And then the last answer choice is D, stigma. Stigma is basically the societal disapproval and judgment of a person or group because they don't fit their norms. So remember how I was talking about in the first paragraph, like, okay, look, what works in America might not work in Pakistan. And that's basically a lot of, there's cultural racism and there are a lot of different social norms that are very different, right? So the passage that talks about educating the public health about the symptoms of depression, raising public health awareness about dementia, and attempting to change attitudes by disseminating like factual information on the disease risks associated with drinking could be underutilized because of social stigma. So and that's why the correct answer would be D in number 47. Now let's look at number 48. This is actually another passage-based question. So it's asking efforts to raise public awareness about dementia in LMICs are most likely to take a form of which community-based program? So this is another passage-based question that focuses on the three disorders again. And here we can focus on paragraph 3. If you organize yourself, you know, okay, dementia is mentioned in the last paragraph. I can just read that one again, or just read the question, the answer choices, and then revisit the paragraph next to it. Here we can focus on the paragraph where the author talks about that dementia. And here there's a mention that there's likely underreporting of dementia in LMICs, and improving dementia surveillance can come in the form of raising public awareness through community-based programs. So we want to get some more details. Like we are thinking right now, even without looking at the answer choices, that raising public awareness about dementia would most likely take the form of this correct answer. So if you go through our four options, we're trying to find the community-based program that would best raise public health awareness. So going to number A, if you're informing people that dementia is an abnormal condition rather than a normal part of aging, that's one way you can actually flag to people in a public health campaign that this is something to look out for. That's already a strong answer choice, but I want to make sure that I'm looking at B, C, and D without eliminating them. So in B, we're talking about educating people about all disorders that can lead to dementia if they're left untreated. Now, like while educating people about the disorders helps inform the public, it's not raising awareness as much as option A, specific to dementia. So giving the public health, like the details about different disorders can be helpful, but we're focusing on raising awareness to answer this question. And revisiting the question, like a community-based program about dementia. And then C is also similar to B, where like that knowledge is helpful, but it's not necessarily raising awareness about dementia. Basically, you want to be able to inform people about the disease and what they should actually look for. And so, a decline in fluid intelligence, and fluid intelligence is basically reasoning and flexible thinking. And so a decline in that is expected as you age. So explaining normal aging symptoms in this case would not be the best way to raise awareness of something that is abnormal, which is option A. And D is basically out of scope because it's helpful information so people can understand how memories can be lost. But in the context of this passage and the question, you need to distinguish between memory interference and memory decay. So this is this could be something people might pick because memory interference is different from memory decay, which is dementia. So having an understanding of what dementia is, and we're going to be talking about that a little bit more next week, where we'll be talking more about aging relating disorders to the brain. Because as our brains age, they don't function as well. But basically, answer choice A is going to be our best answer because you want to raise awareness, like informing people that dementia is an abnormal condition rather than a normal part of aging. All right. And now we're going to go over the next two questions for this passage. The studies in this passage that suggest the determinants of depression are most likely to take an approach consistent with A, B, C, and D. So this is attesting, again, your knowledge about the specific models related to psychology. Here, like it focuses on one of the three disorders. The previous question mentioned dementia, and now this one is focused on depression. So here now I'm going to be focusing in on paragraph 2, where the author talks about depression. And specifically, they say, and I quote, and I'm quoting it from, and I'm reading the passage right now. Studies suggest that structural factors such as poverty, pow poverty, or racial ethnic minority status are significant determinants of depression and LMICs. So we're going to go through each of one of our four answer choices and define them. That's the best way. Like if you know the definition, then you know which one matches that description. That's how you'll find the one that's most consistent with that answer. Dealing with like structural factors like poverty or racial ethnic minority status. So answer choice A, life course, the life course perspective is a theory that basically analyzes people's lives in the context of social, structural, psychological, and biological perspectives. And this approach to health is just going to look at environmental factors, life experiences, and also the social environment and how it affects health. So that means if you're looking into your childhood, adolescent, and adulthood, and all of that ties into your health. And the passage doesn't go into the different stages of life. Like this specific theory, like you'll know it when you see it, basically, because the life course theory, it's really in the name. Like if you're mentioning your childhood, your adolescence, and then your adulthood, and how that affects your life, that's the life course theory. But that's not really mentioned here related to like structural factors. B looks like a strong choice, the social epidemiology model, because that considers the social factors that were explicitly mentioned in the passage. Look, I'm looking at explicitly mentioned things. I'm not trying to extrapolate, and I'm not trying to overthink. This is a good test-taking strategy where a lot of the answers for them can, specifically this section as well, they can really be supported by what's really in the passage. So factors like race, ethnicity, or socioeconomic status rely on social epidemiology. And that also studies the social determinants of health, which is exactly what we're looking for. So this is going to be our best choice so far. But let's look at C as well, which is talking about the biomedical approach, which focuses on the biological or physical aspects of illness. Basically, the biopsychological approach basically highlights the importance of psychological and sociological study. And so I would say it would be a good choice, but unfortunately, we're not focusing on psychological study. We're focusing more so on sociological study. So the biomedical model doesn't necessarily fit here with the social epidemiology. So still social epidemiology still trumps that other choice. And then D is microsociology. Microsociology, I would not know what that is, but I would just pick the best answer and move on. But let's actually figure out why microsociology is incorrect. So microsociology, to my knowledge, is basically the study of the day-to-day and face-to-face interactions with people and small scale groups like families, friends, classes, individual level. Micro sociology instead of macro. So the structural factors are macro sociology related. And so we can still stick with answer choice B, the social epidemiology answer. All right, and then for number 50, this question is asking the concept of medicalization. So I highlighted that because that's another vocab word that we need to know. This concept of medicalization is most directly relevant to which passage statement? So here, these are all direct quotes from the passage. Um, so we're given this vocab word, we need to know what it means in order to understand. So what I'm remembering is that medicalization is basically the effort to um, medicalization is essentially you're medicalizing a disease. That's how I remember. And I know I'm using the word to define the word, but basically it's an effort to describe a type of behavior as a symptom of an underlying illness that should be treated by a doctor. I think that's the simplest way to put it. So, for example, like increasing the effort to medicalize addiction and treat it as a disease of the brain is helpful. And also like adding more diseases to DSM-5, that's another form of medicalization. Um, but it's also been criticized as an attempt, as an attempt on the part of the powerful to control behaviors that are inconsistent with societal demands. So, who says that being a certain way is a disease, right? Like, why is that considered out of the norm? So really, we're just going by the majority and calling whatever's abnormal a disease, right? So that's a flip side of medicalization. But we can say that medicalization involves considering behaviors that weren't previously considered medical conditions as medical conditions. So when I'm looking at it, option, I would say option D is what we're looking for because medicalization involves considering behaviors that weren't considered previous conditions. So here you could see and D, like the emphasis on framing excessive alcohol use as a treatable disorder, and which it is. That's one factor of medicalization. But C is talking about underreporting, but that does not always mean that that disorder has not been medicalized. And B and A are weaker answers compared to C, but basically A is medicalization, which doesn't have to do with research methods. B, while it's helpful information, it doesn't have to do with medicalization. And so that's why D would be the best answer. And you can see here I'm using a combination of extracting the best answer and also eliminating and just using sometimes educated guesses, even if you don't know what medicalization means, and just using context clues. And now here's our last set of two questions for our passage today. And I know it's very long, but really these passages should be taking look, so we have 95 minutes for 59 questions, roughly I think 6 to 8 questions per passage, which means 60 divided by 59. Yeah, roughly a minute per question. But if you're also spending time on the passage, then you need to allocate time appropriately. So my aim would always be finish a passage between 7 to 8 minutes. I know this has been much longer than 7 to 8 minutes because we're going over the explanation and answer choices, but practice helps you do it faster. All right, so number 51, it's asking us the distinction between binge drinking and alcohol dependence. And in this passage is best described as attributing preventable injuries to which effect of alcohol use. So here again, we need to know the definitions of these words. Otherwise, how are we going to be able to answer these questions? Now, my friends and I, we commonly talk about how the PS section is really a game of vocab, because if you know the vocabulary words, the MCAT is asking you to apply them, and just they're just testing if you know them or not. So again, this is a passage-based question focusing on one of the three disorders, which is excessive alcohol use. And so we're going to be looking at the last paragraph, the last part of the passage where the author says, and I'm quoting, excessive alcohol use is also associated with preventable injuries, which are most likely to result from binge drinking than alcohol dependence. So this is attributing preventable injuries to an effect of alcohol use. And so we can define each of our four correct answer choices and decide which is the most correct effect. So A, tolerance. So alcohol tolerance involves the need to consume more alcohol to get the same desired effect. That doesn't have to do with preventable injuries or the risky behavior associated with binge drinking. Um, Disinhibition uh, involves the inability to suppress unwanted or inappropriate behavior, like the behavior associated with binge drinking. So this is what we're looking for in our correct effective alcohol use. And so this B is better than A at least. But let's look at C. Negative reinforcers. They're basically used to remove an unpleasant stimulus to increase the frequency of a behavior. Now this is out of scope because we're not trying to increase alcohol use, and we're not, and negative reinforcement is not mentioned in paragraph 4 when talking about preventable injuries that are more likely to result from binge drinking. And then as for the positive reinforcers are basically added. They add a wanted or a pleasant stimulus to increase or maintain the frequency of a behavior. And this is also out of scope because positive reinforcement was also not mentioned in paragraph 4 or when talking about the preventable injuries associated with binge drinking. So we can actually still stick with answer choice B as the best answer so far. And finally, the last question of this passage. Usually the last questions of passages tend to be the easier ones, so sometimes I do those first. So the passage suggests that family caregivers of patients with dementia are likely to experience what? Now, I don't even need to read the passage to answer this question. That's why I tend to answer the last questions first, because here we're talking about the burden of families, and that really brings me to, that could either be role strain or role conflict. But role strain is basically the stress or strain experienced when an individual like has incompatible behavior or expectations that are associated with society or a single role. But here, the author is telling us, and they explicitly told us that caregivers have to balance caregiving with other social responsibilities. So that comes to answer choice C. So look, A and C are the ones where I would be thinking, I would think, right? My brain would go. But it can be role A because role A is only talking about one role, and role C is talking about multiple roles. So because the author talked about multiple roles or conflict between different roles corresponding to more than one status of an individual, like me as an individual, I have multiple statuses. I am a student, I'm a daughter, and I'm a teacher, right? So if these roles conflict with each other, that's called role conflict. Whereas a role strain is if I'm a daughter and I have a lot of responsibilities to do, pick and drop off sisters from school or work, helping with their homework, that's a role strain because that's related to one role. So so the caregivers in this passage, when they're experiencing role conflict, they have to find a way to balance these multiple roles. So that's why family caregivers experience role conflict. So see, I didn't really have to reference the passage for this question if I knew what the difference is and what family members are experiencing. That's another a good test taking strategy to also save some time. All right. So that really brings me, that's going to help me wrap up that part of like the passage specific and some test taking strategies. But I know that I did score 99th percentile on this section. It was my best and most favorite section on the MCAT, basically because I treated it like a game. I treated it sort of like I need to memorize a bunch of terms. So a couple of resources I had personally used to score a high on the MCAT section for PS. Essentially, I would watch some Khan Academy videos. I did take psychology and sociology as well. Now those are not required prerequisites for medical school, but highly recommended for a reason. So if you focus in these classes, the psychology and sociology, and you remember and you really work hard in those classes, you'll be fine because really is taking those classes is like studying for this section. But I did not really remember what I took because I had taken a couple years before. So instead, what I did was are a couple of documents circulating on Reddit that summarize Khan Academy videos, which really go over the large scope of the PS section. Now, personally, that did not work for me when I did try to read through every single thing because I didn't have it all memorized. So what I used was I used flashcards. You can use Quizlet, you can use Anki. And so I used flashcards and I used pre-made flashcards to save some time that were based on the Kaplan PS books and also specifically also the Reddit basically PDFs that exist for these sections based on Khan Academy, and they are very expansive. They were pretty good, and so I filled in gaps in my knowledge if I did have any gaps in knowledge or any vocab words I did not know using practice questions, specifically Q banks like UWorld or the AAMC Q packs, and also using full length exams to also learn and you use and it's also a matter of reviewing questions that you got wrong and also got right, because every single question has four or five answer choices, and each answer choice is a vocab word that is fair game for them, cat. So even if it's not the correct answer choice or the correct answer for that specific instance, you should still know because it might be the correct answer in another instance or on your actual MCAT. So I would use those answer choices and frame the question, asking myself when I would be reviewing my answers, um, how could this question have been asked differently to have made answer choice C correct instead of answer choice B, for example? And so that would help, and that's sort of how I was playing a game with myself to keep myself motivated and sort of understanding the effectiveness of reviewing, because sometimes reviews would be more effective than just straight up memorizing a bunch of vocabulary. So personally, I did use the mild down Anki deck to memorize or go through my first pass of material, and then to fill in gaps, I used the AEMC material and tried to define gaps in knowledge through that. Hope that was helpful. And now switching into medical school. So I was not sure as a pre-med where all this would fit in, where all the stuff I'm learning about psychology and sociology and social determinants of health will be relevant for medical school specifically. So this question does come up. Either you've asked or I also sometimes ask myself, like, what did we actually learn during the first year of medical school? So I just wanted to share that we just finished our brain and behavior, I guess, course, brain and behavior course, which went over neurology, neuroanatomy, clinical neurology, and also psychiatry at the end. So during my psychiatry block that I finished just yesterday, I can actually talk about like what we learned. So I did want to also emphasize, like, we do need to still remember the MCAT knowledge, specifically from the psych soc section. It is relevant. A lot of it is relevant, and it does come back again to haunt you. Like personality disorders, the Freudian theories, the mechanistic model of psychology, and just understanding these different and considerations for healthcare disparities, and again, social determinants of mental health as well. So we had a lot of lectures on major psychiatric diagnoses, psychopharmacologic interventions. Basically, that's just fancy words for like the different psychotherapies or pharmacological interventions, like psychotherapy, psychodrugs, psychotropic drugs, and other treatment modalities like a CBT, cognitive behavioral therapy, and understanding what that actually means and how that can be used for patients. We also had a lot of clinical correlations and small groups and learning sessions with people living with actual psychiatric diagnoses. We also were able to interview a person who actually is living with a psychiatric diagnosis, and we did a mental status exam on them, which I'll go over in the next slide. And basically, just throughout the psychiatric block, like we considered the social determinants of mental health. We talked about biases and barriers to care that impact many people living with psychiatric diagnoses. One of them that comes to mind is underreporting. Again, underreporting was also mentioned that it happens in lower income countries. It also happens in the US. A lot of illnesses are not fully diagnosed until some people are adults, even though they might have been battling with it or suffering from it their entire lives. So that is just a very brief, I guess, tip of the iceberg summary of what I had learned during this block. And it was an amazing section. I really liked it and I learned a lot. So I highly recommend. And there's always a light at the end of the tunnel. Like, why am I studying this MCAT stuff? When am I actually want to get into actual patient and clinical care? Dr. Chima mentioned in her case study, it is very relevant. We will see a 14-year-old girl like that or a very similar story, and knowing but the tools, being able to have the tools to really prepare ourselves to see these patients and care for them is really motivational. So I talked briefly about the mental status exam in the previous slide, but basically the mental status exam, a psychiatrist told me, essentially it's the physical exam of a psychiatrist. So basically psychiatrists, they don't do your typical like neuro exams or your abdominal exams. They're not checking your heart and lungs. I mean, they can, they're trained to, but the mental status exam specifically is done by psychiatrists, and it's termed this physical exam for them. Basically, the key components of the mental status exam include general appearance and behavior, speech, mood and affect, the thought process, thought content, conceptual or perceptual disturbances, and also sometimes an MMSE or a mini mental status exam or a MOCA, a Montreal Cognitive Examination, is done. And then finally, assessment of insight and judgment of the patient as we're interviewing them. So I'll actually talk a little bit more specifically what each one means. So this is sort of a cheat sheet, a mental status examination worksheet that was given to us when we were interviewing our patients. So basically, I had a patient come in and I had to analyze her appearance, and so appearance, the more vivid the better. So it can really be as descriptive as you like it to be. So if it was a like a it can be you can talk about their hair, their facial hair, how well groomed they are, their eyes, like did they make appropriate eye contact with you, were they making any abnormal movements when they were talking to you during the exam. So these aren't things you're asking the patient, these are things you're actually analyzing while you're talking to them, while you're making these observations in your head, or you're sort of taking down notes as you're talking to them. Probably not like note taking as you're talking, because patients prefer that you talk to them, but just trying to be as approachable as possible with your patients and being able to just have a conversation with them, understand why they're there, while also assessing like, are their clothes dirty? Are there any holes in their clothes? So these are things that you would note down. And then there's behavior and attitude. Behavior and attitude are a little bit different. For example, like how did your patient behave when you first met? Were they cooperative? Were they indifferent? Were they apathetic? Were they agitated when you talked to them? So we're lucky because it was our first psychiatric patient. They were all cooperative. They were being paid to teach us, right? As our actual psychiatric patients. So, or were they pacing? Were they walking? What was their eye contact towards you? So you basically write in the chart, like if you're writing out a mental status exam, you would write out they were thoughtful in their speech, or they had a cooperative behavior and a cooperative speech, and and what was their quality of volume in speech? Were they talking very fast like this? Were they talking very loud, or were they talking very, very slowly, or very, very like softly, and it was hard to hear them? So you can comment on all of these things. These are all things that you want to try to assess for their speech, behavior, and attitude. And then there's affect and mood. Now, affect and mood are different. I had to learn this as well, and this is very high yield. When you see high yield is essentially like a high yield topic, a topic that comes up very commonly. What is the difference between affect and mood? Essentially, mood is is uh, is basically reported by the patient. So you ask the patient, "How are you feeling today? How's it going?" And or to say, "I'm fine." You just put in quotations, "I'm fine." That's the reported mood of the patient. Now, the affect of the patient is really what you assess. So if a patient is saying, "I'm good," but there are tears streaming down their cheeks, that means that they are not actually good. They're not actually matching the reported mood. Their affect is sad. Their affect is unhappy. Their affect could be gloomy or depressed if there's tears coming down or streaming down their cheeks. So you always want to compare affect and mood. You want to see, do they match? Because sometimes patients might be reporting one thing, they might be feeling a certain thing, but their affect or their actual observed emotion at that time may be very different. And look, there's also an intensity, the qualities of affect. A flat affect is basically someone who just talks the same way the entire time and does not have enunciations in their voices to try to basically try to communicate. So we're assessing their communication skills. It is a lot at once, right? It sounds like a lot, but once we practice and once we understand what each of these terms mean, what we're looking for, and then of course, you have your mentors to help and assist you. So it's really not it's not as daunting as it looks right now. But of course, when I first learned about it, what was it like 4 weeks ago? It was a little bit overwhelming for me. And then there's a thought process, thought content. Now I'm still learning these myself, but basically a thought process is basically when you ask a patient a question, and this basically is essentially asking you, is the patient getting to the point? Like if you ask them, so um, how many medications do you take? Now, a patient could say, "Oh, that reminds me of that one day that I was walking in the park, walking my dog." Now, patients do actually talk like that, and maybe they might make tangents or a looseness of associations, or they might just have this completely disorganized speech. So there's this level, you could say, like they could either be circumstantial, as in like they will talk, but they'll sort of like circumstantially come back to the point and then actually answer your question at the end, or they just don't even answer your question fully. They just talk about something else, even though they did process your question. They're very important things to keep in mind. And then also thought content. You ask them if a patient is having hallucinations, you can ask them how long it's been going for. Are they occurring right now? Are you hearing voices? Are you seeing something that other people don't see? Now, you're not trying to say like are you seeing something that's not actually there? Because to them, it might actually be there. So it is important to think about and keep in mind because you want to be empathetic towards your patients. Some patients still believe that there are things that are there that may not be there for others. So just being cognizant and empathetic towards your patients and just really not judging them because of course there are patients. And then there's something called the cognitive exam that we do towards the end. There are a couple of different types. There's a mini mental status exam that we'll get into if you have some time. But basically, it's an exam where you're asked a series of questions to see if the patient has delayed recall, if they can assess what's in the room currently, if they can count backwards by sevens, if they can spell the word world backwards. Things like that. And then there's also the MOCA, the Montreal Cognitive Assessment. Basically, I don't know, there was one of our previous presidents had done the MOCA and he was talking about it. So that's when the MOCA was sort of on the news, and you can also research that yourself. And finally, judgment and insight. How do you actually tell insight? So you can assess that based on how the patient presents their problems, how they're acknowledging if they have a psychiatric illness or not, how they use their ability to judge to actually arrive to a specific decision. So they need to, you're sort of assessing if they're you're assessing their orientation to place, time, and space. So I'll stop there. That is basically what I've been learning and still working on learning in medical school, working on actually applying what we learned all the way from the pre-med psych 101 classes all the way to now using the mental status exam and understanding the different types of treatments that are used for various psychiatric illnesses. And now I'll kick it off to Dr. Chima to sort of also analyze and really tell us the importance of well-being in self.
Thank you, Minahid. I really appreciate. Definitely, these MCARE skills will help our students, and I really appreciate your time. So, as we talk about our self, every session I talk about self-care. So, why I do talk about it? Why do we need self-care? So, as you're going to be a future healthcare professionals, so healthcare professionals face overwhelming demands and experienced crisis levels of burnout. So that's why we must be vigilant for signs of burnout and depression that we talk about it within ourselves and among our colleagues, among our friends, among our family members. And we must not hesitate to seek help whenever we need it, whenever we recognize someone else around us having such symptoms. And during our training as a physician, we physicians do practice resilience and self reliance in abundance, like we have a long hour calls, right? So, but when we rely on those traits above all others, we put our own well-being, our own self-care, and that are for that of our patients as well and our colleagues at risk. So that's a reason I all in all my sessions, few minutes I talk about the self-care. So I will go over again. There are 4 areas, 4 domains we need to keep in mind that we have to care ourselves as well. Because the reason if we will not take care of ourselves, how will we take care of others, right? When we go in the plane, sometimes there's oxygen level drops. So the staff told us, put the oxygen mask first on your face and then help next to you, right? That why? Why they tell us like this? Because if our oxygen level is low, we will not be able to function appropriately, right? So then how we can help others? So there's a reason it's very important. I talk about self-care in every session. I try my best. I know some people feel like who are listening to my sessions every time, they feel something bored, but it's okay. It's a revision, it's a reminder that we have to take care of ourselves as well. So 4 main domains I always talk about: physical health. It's called PQ. Exercises, diet, I call it self. S for sleep, E for exercise, L for learn how to manage stress, F for food, eat healthy food. And then emotional health, emotional intelligence. This is a concept first time given in 1995 by Daniel Goleman. What is all about? It's emotions. As we talk about the limbic system, we talk about the amygdala is the main anatomy of the brain that helps us with our emotions. So we need to be very highly emotionally intelligent as well beside our IQ. And it's being said to get in the job, you get high scores, you get med school, high IQ, but to keep in that program, to keep through that, to follow how to get over the burden, we need EQ, how to deal with it. Then IQ, of course, our mental health, our mind health, our every time we need to learn new stuff, it helps us to open up a new brain, neurons. And then most importantly, last but not least, our spiritual health. What is spiritual health? Means our purpose of life. Find why we're in this world, why we woke up this morning. I always tell my patient, count your blessings. We all are blessed this morning. We all woke up this morning. There are many people who could not make it this morning. They're 6 feet below the ground. So we are all blessed, right? Smile, add value in other people's life. That's very important. Start from now. Start thinking back to the community. Don't think that you have to be a doctor, then you start doing it. Start small action. Even 5 minutes, help your friend, help your colleague, help your family member, help your siblings. Try to add value in other people's life. All right, last but not least, I will go over pretty quick again, keys to success. Why we need a reminder again. There's no magic in this world. Everything is practice, practice, practice. As modules were mentioned, there are a lot of material we need to memorize, a lot of concept we need to digest. So how we can do that? Just chop that information. So, and then most importantly, practice, practice, practice. If you don't know first time, go over again second time, third time, fourth time. So what you're doing, you're going over that material over and over again. And then it will stick to a hippocampus. Remember, we talk about the anatomy of the brain. Hippocampus is the organ that helps with the memorization. So I'm just bringing up those parts of neuroanatomy or brain anatomy so you'll remember the areas of memorization. The hippocampus will help us. Amygdala with our emotions. Anyways, so no magic in this world. Practice, practice, practice. Always I say your passion and profession should be the same. Then you're not working even a single day. So why we are here together on this Saturday morning? I always try to remind myself and remind you as well. But think about it. Why we are spending this hour together, right? Saturday morning, we can do something else, right? Go out, go for a walk, go for that. That's very good. You should. You spend time doing some fun stuff. But over here, we are here to learn something, to add values in someone's life. So I always tell one candle lit another candle. So help others, pass on to other people, and then prioritize. So you have to prioritize what is important at this time. And there's a very good book called Die Empty. Whatever you have learned, whatever you have, try to give it to other people. It's a good advice. It's a good smile. I always tell my patient, smile at the end of my encounter. So smile. It's just small a gesture, right? You're adding value to someone's life. You're giving someone good hormones. When you smile, other person smile. And I always tell emotions are very contagious. You know, like when babies smile, we all smile automatically, even regardless we are stressed. When baby smiles, we start smiling, right? So emotions are very contagious. So start adding values in other people's life, and most importantly, perseverance, persistent. Have a commitment. What is a commitment? Commitment is that you have a pledge. It's a promise that you have to make yourself. You have to do some tasks, some goals in your life in future. What you need to do fulfill your commitment. Be disciplined, self-discipline. Self-discipline is equal to success. So always remember, never give up. If you have committed yourself, if you have decided you have to do it, have a great continue, be persistent, consistency, that matters. I'm telling you. Never ever give up. Don't be disheartened. Sometimes your grades are low. Sometimes, oh, I cannot make it. No. I always tell my students, take the word out, can't from your dictionary. There's nothing impossible in this world. I always remind my students, impossible word itself saying, if you chop that word impossible, I am possible, right? So impossible, I am possible. So impossible word itself saying I'm possible. So how come? So nothing is impossible in the world. Yes, definitely. When you commit something, when you are persistent, it needs sacrifices. But when you're self-disciplined, just try and make schedule, prioritize, and of course your self-care as well. And then slowly take small baby steps. And then one day you will achieve your goals. And one day you will be, then you think like, when I tell my students, always count your blessings, just always think a year before, like today is March 9th, 2024. So think about March 9th, 2023. So just comparison, this will help you where you were a year before and where you are right now, right? From physical health standpoint, from emotional health, from your spiritual health, from your IQ level, right? You have learned a lot. So always try to practice just for 5 minutes, just for a few minutes, all these 4 areas, PQ, EQ, IQ, SQ. All right, so I will stop here, and I'll wish you all good luck, and always keep smile on your face so you have a good hormones in your body and you will stay healthy. and you will be a good future professional, health professional, and you will start adding more values in other people's life. Best of luck, everyone. I'll stop here. Thank you so much.
Thank you very much, Dr. Chima. I know that that is the dose, the weekly dose of motivation that I truly enjoy receiving. So our next week's well first our teleshadowing quiz is now live for this session. You'll need a 70% or higher to pass. It is at teleshadowing.com/certification. And next week's session will be on clinical neurology, specifically dementia, Alzheimer's, and Parkinson's diseases, sort of the diseases of aging. So I'm excited for that. And I'll basically be the last session of our neurology month. We'll be taking a brief break for a spring break, and then we'll be coming back in April for our GI or gastrointestinal diseases month. So thank you so much, everyone, for tuning in and coming today. I hope everything was helpful. Feel free to reach out to me at learn@teleshine.com if you have any questions. And have a wonderful rest of your day. Thank you.